All right, so today we have Dr. Mandar Jadhav, who joined the National Association of Community Health Centers as Deputy Director of Federal Affairs in 2023 to bolster congressional engagement. He previously worked as a health policy advisor for the U.S. Senate Committee on Health, Education, Labor, and Pensions. Dr. Jadhav is also a pediatric psychiatrist who completed training at Penn State Health and the Johns Hopkins Hospital. He draws upon both his clinical skills and health policy experience when advancing the health center movement's goals on Capitol Hill. Dr. Jadhav, we're all yours.
Thank you very much for your time and interest in the health centers and public policy. So I see that the group is pretty small and just wanted to give folks a few minutes to just introduce themselves, share a little bit about who you are, what stage of your career you're at, and if there's any particular area that you're interested in as pertains to health policy or the health system. Because I could be as brief or as detailed as you'd like, so I want to be responsive to what folks are interested in.
I can go ahead. I can go first. My name is Anana. I just finished my first year of medical school at Morehouse. Um, I would say I'm leaning towards doing something in pain medicine. I would love to work at a community health clinic, so I'm especially excited for this talk. I will tap on Zachary to introduce himself next.
Uh, my name's Zachary. I'm a actually incoming medical student at the University of California, Riverside. So I'll be starting this fall. Currently interested in primary care and definitely not ruling out the possibility of working at a health center or community health center at this point of my career.
Natalia, Jay, and then Caitlin.
Hi, I'm Natalia. I am a rising second year medical student at Drexel University. Um, I'm currently undecided, but I do have an interest in food as medicine and rural healthcare. So that's me.
Hello, everyone, and hello, Dr. Jadhav. Thank you for being here today. My name is Jay. I am, like a lot of these guys, I just finished my first year of medical school at Rowan in South Jersey, and I think I might be interested in emergency medicine as far as specialty wise, but health policy wise, I'm very interested in finding out how to, figuring out health insurance and a better way of doing things, I think.
Hi, I'm Caitlin. I am also a rising second year medical student at Rowan Virtua in South Jersey. Like Jay, I'm also leaning towards maybe emergency medicine, but still keeping an open mind. And as for health policy, definitely interested in learning more about expanding access to coverage and improving affordability overall.
Mackenzie, Trinity, and Therese.
Kenzie. I also just finished my first year of medical school at the Renaissance School of Medicine in Long Island, and I'm undecided about specialty, leaning towards potentially oncology, and I don't have in-depth knowledge of health policy, so I'm very interested in kind of getting a breadth of understanding of it.
Hi, I'm Trinity. I am also a rising second year medical student at Creighton in Phoenix. I'm kind of leaning towards pediatrics at this point, but also kind of open to other specialties, but generally hope to be working in a community health center in the future.
Hi, I'm Therese. I just finished my first year at Cooper Medical School in New Jersey. Right now, I'm pretty interested in IM and then maybe specializing in ID. In terms of policy, I'm pretty interested in ending poverty both domestically and globally. So domestically, like things like affordable housing, and then like globally, maybe like neglected tropical diseases. Um,
And I think we had Lauren just join.
Yeah, hi. Sorry, I had some signal issues. My name is Lauren. I not sure what else I'm supposed to share. I just finished my first year at Creighton in Phoenix. I'm interested in neurology and working in community health.
Well, thank you all for sharing a little bit about your interests and where you are in your career. That's really helpful for me to understand as well. And I'll speak to a couple of things over the next 20 minutes or so, and then maybe we can do Q&A. So partly, I think Dr. Malik had reached out to me because you all and he had some interest in what the landscape looks like with these community health centers or federally qualified health centers, where they fit into the larger healthcare system, and how overall our health system kind of functions when it comes to most people that want to access, say, outpatient primary care preventative health type services. And then two, I can kind of speak to where you might find a place in this part of the health system when it comes to either being a clinician or a health policy leader or, advocating for healthcare reform, things like that. So that's how I'll try to split it. I'm not going to use any slides or anything like that. Personally, not a big fan of PowerPoint, but if you'd like, we can, share some resources with you afterwards. So, just a very quick recap of how our health system is structured and how some other health systems are structured, just as a point of reference. So, our health system is pretty heterogeneous. It doesn't really have any sort of singular uniformity in how it's designed. And we can think of that in multiple ways. We can think of it from who pays for healthcare, who accesses healthcare, and who provides healthcare. Those could be different ways in which you slice it. So if we look at it from the perspective of who accesses healthcare, it's pretty much everyone, right? Everyone who lives or is a resident of or a citizen of our country, whether it's in the 48 states that are conjoined, or you go to Alaska, Hawaii, the territories, the islands. If we just look at the US specifically. And of these people, you could be someone who's very low income, very high income, or somewhere in between. And so, depending on that, it might affect how you afford or access your health services. That's one way to look at it, is who's accessing healthcare. And we can add more and more detail to that. You could be someone who's very healthy. You could be someone who's very sick with multiple chronic conditions. You could be someone who's on the younger end of the age spectrum or older. That's other ways that you could look at it from the patient's perspective. And of course, all of us in this room, this virtual room, are also going to be patients at some point if we haven't been already. Odds are we've all already been patients because most of us have had childhood vaccines, if absolutely no other healthcare. And in that way, we can also correlate and understand and empathize with the patient experience, even if we're healthcare providers or involved in health policy. So that's the patient perspective. If you compare that perspective in the US with a patient, say, in a more sort of standardized healthcare system, you could look at comparable GDP countries like the UK or some of the European nations, and oftentimes they have something like a nationalized healthcare system. And so that has certain benefits and certain downsides to it. And then if you look at some of the developing nations, many of them do actually have a safety net healthcare system as well that anyone can access, even if they're lower income nations. But then there can be some private sector participation in that system where you can access more or better care sometimes if you have more resources. So that's from the patient standpoint. If you look at it from the provider or doctor standpoint, right, you could be working in a system that is, again, homogeneous or heterogeneous, and the US is heterogeneous. So you could be doing private practice here, you could be working for a large system, or you could be doing, these days, you could be doing telehealth where you're doing partly services in an employed setting or your own practice and partly with other people. And when you compare it to other places across the country, across the globe, you'll see again, depending on the design of the healthcare system, you're kind of serving a different role as a provider, as a doctor. So in very low resource nations, say in certain parts of, say, sub-Saharan Africa, for example, there's not really a lot of healthcare infrastructure for the doctors. And so a lot of it is with you're doing home visits or you're doing community fairs or you're doing ad hoc type of service locations. And if any of you have learned about or had exposure to some of these things like the AmeriCorps type programs that help people go and address overseas needs, you might have seen some of these types of systems. In very standardized, nationalized healthcare systems, pretty much all doctors or providers are employed by that system, like in the UK, for example. So there may be a salary structure that gives you a certain amount of stability in that setting. And then you could have your own patients outside of that system. But the US is very heterogeneous. So as a doctor, as a provider, and you all also spoke about specialties, right? Each of you has a slightly different interest area right now. And so your practice could look very different depending on whether you're an oncologist, you're a pain medicine person, or you're a primary care, you're a pediatrician, internal medicine. Each of you could have a different side of your clinical work. And so you could be seeing people in the hospital primarily, you could be seeing them in your own office or employed by a larger organization. Or these days with certain professions like, say, radiology, you might never see a patient. You might be only on your computer somewhere in a completely different state, reading images from someone who's you've never met before. So there's two of ways to look at the healthcare system. And then the third one, which is kind of interesting in the US, is the payer mix or who's paying for healthcare. So the US is largely an indirect payment system, unlike some countries, and yet other countries which also have indirect payments operate differently. And what I mean by that is, just show of hands, the last time you went to your doctor, did you get asked about what was the first question that they asked you? And I could take one or two people volunteering to answer. What was the first question that you got when you walked up to your doctor's office staff the last time you went there?
Maybe for my ID and insurance card.
Right. Anybody else have a different experience?
I think for me it was name and date of birth.
Okay. So you're absolutely right that the identity is certainly important. You would want to have any healthcare provider ask you your identity information. Granted, if you are lucky enough to have the same doctor for most of your life, they might actually know you by sight. And this is becoming more and more rare as healthcare gets more consolidated in our country. But Jay pointed out that usually one of the first questions is also, can you give me your insurance card? Or what type of insurance do you have? And that speaks to the peer or who pays for healthcare. So most of us have some type of insurance that pays for much of our healthcare, both in doctor's offices as well as in hospitals. And generally speaking, we have a choice of insurance products, either because we are buying it off of a marketplace, or you have an employer or a school or a parent that's gotten a choice of a health plan through their job and you're just signed up for it. And what that means is you're paying in two different locations. You're paying first an insurance premium, and then second, either a copay or a deductible or a cost share when you go to your doctor's office. And sometimes afterwards, you get an additional bill from your insurer for things that they don't want to pay for. So that's an indirect payment system versus somewhere where you could just go to the doctor's office. Doctor says, you give me $100 and you just give them the cash and that's it. And there's no further transactions involved. That's a direct payment system. And you could have a universal healthcare system that's indirect, like the National Health Service in the UK, or you can have our system where there's multiple payers. And some of the major payers in our country are Medicare, which is largely for senior citizens and some people with disabilities. You have the private payers, which is the employer provided insurance plans as well as marketplace plans, the Obamacare or Affordable Care Act marketplace. So these are folks like United Healthcare and Aetna and Anthem and Cigna and all of these other guys. And then you have the armed services, which is the DoD and the VA have their own health insurance system. That's as close to the National Health Service in the UK as you can get. And then finally, there's the Medicaid system for folks that are generally speaking on the lower end of the income spectrum, or their kids, or more lately, women who are pregnant or postpartum are also generally also covered by Medicaid. And that's a partnership between states and the federal government. So that's a mix of money that goes into that system. So those are your major payers. And now if we look at, who's the payer in the primary healthcare system, the preventative healthcare system, usually the biggest payer is Medicaid. And outside of Medicaid, then you have all these other plans. And then there's a portion of our population that has no health insurance. And that can happen for any number of reasons. You could be someone who's experiencing homelessness, or you're in the middle of severe addiction challenges, or you're between jobs. You've lost a job, but you haven't found a new one. You could be someone who doesn't have the appropriate documentation, and you're in this country without that documentation. You might not have health insurance. So all of these people sort of collectively form that uninsured pool where we've also got to take care of them, but who's going to pay for that healthcare? That's an open question. And so in that context is where the community health centers come into the play, right? So community health centers, I sent around a link and an article through Dr. Malik earlier. And if you had a chance to look at it, they're both pretty good summaries. But if you haven't, I'll just do a quick highlights reel. So community health centers is a colloquial term. It doesn't inherently mean anything. Have any of you heard of, I heard one or two of you talking about community health centers. Have any of you either seen one or used one or thought about, I think a couple of you said you might want to work in one. So just curious if anyone's ever been to a community health center yet. Lauren has. Talia, I see you nodding your head. And do you know what it was called? What was the name of that health center that you went to?
I guess I'm assuming it's a community health center. It's the Moab Free Health Clinic.
Yeah, that's a good point. So sometimes there's also things called free health clinics or free clinics. There's specific organizations that are also called health centers for the homeless. There's migrant health centers, farm worker health centers, and all of these entities collectively are called community health centers. But specifically, community health center refers to a specific type of organization from a legal standpoint. It's a nonprofit organization that has to have a board that governs the organization, and that board has to be made up of majority patients, right? So 51% of the board that governs the health center organization has to be patients. So that's a unique feature of these organizations because you don't necessarily see that with hospitals or private clinics. Second being that they're nonprofits. So that means that the majority of the money that they earn goes back into taking care of their patients or staff. And there's about 1,500 such organizations across the country. They're located at about 15,000 locations, and there's one in every congressional district except for two, and definitely one in every state as well as the territories. So you might not know that it's a community health center because they're called different things. Each of them has their own branding. And for example, in New Jersey, if you see a health center called Zafal Health Clinic, or if you see Eric Chandler Health Center at the Rutgers campus in New Brunswick, or if you are in, I think I heard Nebraska. So Nebraska has a network of health centers that is a member of something called Health Center Association of Nebraska. So there's a bunch of these clinics. They're not necessarily called the same thing. So you might not always know that you're going to a community health center. The second feature of community health centers that defines them is that they're required to take care of anyone who walks through the door, regardless of whether they have insurance and regardless of what sort of income they have, and regardless of their immigration status. So all that a health center is required to do is if you go up to the front desk and say, I need to see a doctor or a provider, they're supposed to ask you, can you give us some form of ID, just like a doctor's office? And do you have insurance? If the patient says no, then the health center asks them, well, this might result in a bill. So if you could tell us what your income is or what you can afford, depending on that answer, they can either provide a free service and not charge the patient. So if they're under 100% of the federal poverty level, they won't charge the patient. Or if they have income between 100% to 200% of the federal poverty level, they'll charge them a sliding fee scale amount, which means whatever they can afford. And then above 200%, generally speaking, most of those patients do have some type of insurance, in which case the health center bills the insurance, whichever insurance it is. So that's what a health center does in terms of access. In terms of services, the primary function is to provide primary health care. So that's things like your well checks, your vaccines, your sports physicals. If you have an infection or if you have pain, you can go to a health center and they'll try to help you with that. Just like a family medicine doctor would, or an internal medicine doctor or a pediatrician would. In addition to that, a lot of health centers also offer access to psychotherapy services in-house. A lot of them also do dental screenings because they have dental hygienists on staff. Many of them have started to do vision screenings and hearing screenings using folks like audiologists and optometrists. Additionally, a lot of these health centers also have access to pharmacies, either because they have a pharmacist on staff or they work with a pharmacy in the community that provides access to medication. So that's kind of the design of the health center from an operations standpoint. And since you all are future physicians or physicians in training, health centers have about, on the clinical side, about 16,000 doctors across the whole country. Most of them are family medicine doctors, and about the same number of nurse practitioners and physician assistants that also provide direct clinical services, and then a bunch of other staff that does all the other stuff. So that's the workforce. And then as far as how do health centers support themselves? So health centers have 3 or 4 different sources of income upon which they rely. One big source is Medicaid, because 50% of the health center patient population is Medicaid patients. So if you've been paying attention to the news, there's legislation in the works that would result in somewhere along the lines of $700-800 billion in cuts to the Medicaid program over the next 10 years. It's very likely to get enacted in the next couple of weeks. And so if that happens, certainly health centers would be significantly impacted by a reduction in Medicaid payments. The second big payer for health centers is Medicare, which is about 10 to 11% of our patient mix, and many of those folks are also Medicaid beneficiaries. So this population can be called the dually eligible population for Medicaid and Medicare. And so that's mostly seniors with low incomes or disabilities. And then the third mix is, depending on the state, marketplace plan, the Obamacare plans or ACA plans. And again, in this bill that is supposed to cut Medicaid, it's also going to likely cut or not extend subsidies that help people access the Obamacare plans. So we'll likely see a negative effect from that as well. And then the remaining population is uninsured at health centers. So in order to take care of these uninsured patients, what we get is the federal government gives us a grant that supports our taking care of uninsured patients. And that grant has to be renewed usually every year to every 2 years. And so that's another thing that, we're coming up in 3 months or so. There's those funds are expiring. So we have to convince Congress every year and every couple of years to extend those grant funds. So we're in the process of doing that as well. And then finally, a program that you may or may not have heard of is called the 340B Drug Discount Program. If you're deep in health policy or you live in the Washington, D.C. area, your YouTube videos might be filled with ads about 340B, but otherwise you might have never heard of the program. So show of hands, how many of you have heard of 340B? So I'll call on Zach as our volunteer to share what he has heard of with 340B.
Yeah, I've only heard about it in the context of like the federally qualified health centers will use it to get a discount on pharmaceutical, dr like whatever, and then sell it. And it'll be a large, in some cases, they're able to use it as a large stream of revenue. But I haven't independently verified that fact, but I know it discounts pharmaceutical drug prices.
Zach, you have a future in federal policy. I think I can see you working for either big pharma or big hospital as a government affairs guy. So I think you have got a head start just because most people haven't heard about 340B, and those who have don't want to think about it. So thank you for volunteering that answer. And you actually summarized it very well. It's a program by which the federal government requires manufacturers to provide discounted drugs to safety net hospitals and clinics like community health centers. And when the manufacturer provides those drugs, most of them go to the uninsured who can't afford those drugs, so they get low price drugs. But there's a little bit of surplus usually because they're bought in bulk. And if there is a surplus, we are allowed to bill insurance, certain types of insurance for those drugs at insurance prices. So the gap that is generated by that additional billing, those savings, we can take those savings and invest them in more patient services. Like, let's say I have a diabetic patient and I need to give him a diabetic foot prosthetic, like a boot to keep them from getting ulcer, or they don't have transportation and they need an Uber to get home or to the clinic. Those are the types of services that health centers put the money back into when they get 340B savings. And like you said, Zach, there's different health centers have different amounts that they recover from this program, so it's varied. But that is another program that is under some amount of scrutiny lately, so we're working on that as well. So that's an overview of health centers. I think I've probably given you TMI, and you're probably zoned out a little bit right now. So I just wanted to see if there's anything that you guys are interested in learning about specifically with health centers, or if you're interested in from a career standpoint, I can go into that next.
I just had a quick question. Other than kind of like the official like title and guidelines for a community health center, how is that different from what like a safety net hospital does, for instance?
That's a great question. So, safety net hospitals are also absolutely essential because we definitely all need, at some point in our lives, we might need to go to an ER, for example, or get admitted to an inpatient unit or an ICU. So, with safety net hospitals, generally speaking, they also have a pretty high Medicaid patient volume. So they're also very dependent on Medicaid. And they often do provide a lot of uncompensated or uninsured care. So they are also dependent on things like the 340B program, for example, and additional government payments. What is usually different with safety net hospitals, although not every single one of them, is there's not necessarily a requirement that they have a or patient majority governance board. That's one example. And then second is that the health centers, as part of getting government grant funding, also have a bunch of other requirements on services that they must provide all of their patients, regardless of their insurance status, regardless of anything else. So that can sometimes be one point of difference. Another point of difference is health centers are, for the most part, focused on outpatient primary care and preventative health services, whereas safety net hospitals, understandably, are more focused on emergency and intensive care services.
Thank you.
Good question.
When I read some of the links that you had sent us, and I was actually really interested in the governance of CHCs, and I wanted to know a little bit more about how having a consumer majority board has held up over time, and kind of what the benefits but also challenges of recruiting for that board and maintaining that board are.
That's another great question. And you're absolutely right that when you want to recruit for a patient majority governance board, certainly it takes some amount of buy-in from your patient community, because most of these board members don't really get any significant compensation. It's voluntary service. They might get some expenses covered. For example, when they attend one of the National Association's conferences, that expense might be covered by the organization. But so it is a labor of love for a lot of these folks that volunteer. One of the reasons and one of the patterns that we've seen in who volunteers for these boards is people who have either been patients for generations, like their parents and their parents' parents were also patients there, or they had a child and now they're also going to the health center. Sometimes it's patients who are also providers. So it's not unusual to see someone who works at a health center also gets their health care at a health center, like a nurse, for example, or a medical assistant. And another reason why people sometimes volunteer is because one of the things that all of us like in our healthcare experience is to feel like we are empowered to make our own decisions and have a degree of say in how we are treated. So that can be a good, strong motivating factor. If you feel, for example, that your community, there's a lot of, let's say, Korean-speaking immigrants, or let's say you live in a community where there's a lot of folks that speak a African language, right? And you feel that the health center doesn't have enough providers who provide language-based services, the ones that your community wants. Then as a board member, you can influence the health center's decisions, on hiring and getting more folks that are language competent into that organization. So that's sometimes a motivating factor.
I was wondering what the process is like when community health centers reapply for grants. Do they look at the quality improvement metrics, or is it typically like a given that if they reapply, they're going to get the money?
Good question. So health centers, by default, all of them are required to report to HHS, the Health and Human Services Department. Every year, they report some patient measures, some staff measures, and process and outcome measures through something called the Uniform Data System. So, for example, if you're interested, if you go to uds.hrsa.gov, you'll see that there's a publicly available data set that gets updated every year that you can go in and look up whatever information that they report. So that's one way in which they're held accountable. Another way is that this organization, now HRSA is being reorganized into something called the Administration for a Healthy America. So these links might change in the future. But one of the things that they do is offer quality certifications or badges, if you will. And so a lot of times when health centers perform particularly well on these standardized measures, they can, show off their excellence by showing off one of these badges, if you will. And then in terms of the grant itself, health centers, generally speaking, if they have been doing the same set of services for a long time, there's not been historically too much scrutiny into every single time that they have to get their grant renewed. But especially over the last 6 months, there's been constantly changing requirements where the government has asked health centers to provide more and more information at each renewal of not just a new grant, but just like standard payments, monthly payments that they're supposed to get already. And a lot of it has to do lately with complying with the administration's executive orders on things like diversity in hiring and things like gender affirming care, things like that, where the executive orders are trying to enforce certain policies. The government has started asking for more information more routinely. And if they don't like what they see, they will steer the health center to try to provide more information or change their policies.
Thank you.
Um, just going back to the 340B, who is attacking the policy? Is it like the pharmaceutical companies, or I'm a bit confused. It seems like there might be multiple.
Yeah, that's a great question too, Zach. And so 340B, one of the things, the trends that has happened over time is that the estimated amount of discounts or savings, if you will, has ballooned over the last 10 years or so. And from what we can tell, a lot of that increase has been attributed to hospitals that have bought other hospitals. And when they get into a pretty large health system, they've been sometimes using their structure to get more access to these discounts or savings from the program, from the manufacturers and insurers. And I'll give you an example. There was some reporting, I think it was the New York Times, maybe last year, referring to a hospital in Virginia and I think a hospital in Ohio that is a pretty large health system now. And what they were seemingly doing, according to this story, is they would go and buy a hospital in, say, a safety net area or like a rural area, which would qualify for the 340B savings. And then what they would do is using that status, they would just acquire medication for all of their patients, even in their urban centers with, you know, a patient mix that was largely privately insured. And so indirectly, that would inflate the amount of savings or discounts generated because they were kind of using these discounted drugs and billing a lot of those to insurance and not necessarily putting all of that back into the safety net hospital or rural facility that they acquired. Sometimes that facility would eventually close down or shrink significantly, but you know they would continue to have the status that they needed to acquire the discounts or savings. Now, of course, the health systems that were covered in these news stories have challenged those type of allegations, and they've said that you know they are investing in taking care of their patients, but that's not being appropriately reported. And so I can't say how much truth there is to either side of that story, but certainly industry, the pharmaceutical companies have noticed, and certainly as private organizations, their primary objective, especially if they're publicly traded organizations, is to increase shareholder value. And the way you do that is show growth in profits. And so for a pharmaceutical industry, if they see that some of that profit portion is being taken away from them, then they would be upset about it. And so they've been advocating with state governments and federal government to try to put in some restrictions on and some additional accounting and reporting requirements on the 340B program and who gets to use it. So that's the two major players. And then for organizations like community health centers, which are actually like less than 5% of that system, and are required by law to reinvest all of the money into patient care services. and patient-facing staff, you're sort of swept into that fight, if you will. And so that's kind of what's been bubbling up in the 340B space lately.
Thank you.
So I have a question for you, unless, okay, go ahead.
Sorry, I was just gonna ask you if you could speak a little bit like about your like how you got involved with policy and what work you've done.
Yeah, so I was actually going to first flip that question on you and ask you all how you got interested in uh, specifically, taking on this internship and some thoughts on where you see yourself being involved in the policy space. And then I can kind of get into my story a little bit.
I can start. Um, I so particularly this internship, I was just interested in formally getting some sort of education on how the US health system works and using that information to kind of parse what I think my role in advocating for reform of the industry would be. Uh, as of right now, I know physicians don't have much say in health policy, especially at the system level. So I've been looking into ways to like increase physician autonomy and kind of bring them back to the leaders of the healthcare system. And I mainly have been looking through physician unionization as a method to kind of do that, but definitely interested in any aspect of legislation. But as of right now, physician unionization is what I'm kind of exploring. And then Anana, I'll go over to you.
Thank you. Honestly, after my first year of med school, I did a bunch of research before I came here. So I knew I didn't want to spend my summer doing more research. So I was kind of looking for something a little bit more fulfilling. I knew I wanted to do some sort of advocacy work. And then this internship kind of popped up. And I thought it was perfect because I think I spent maybe, or we were taught maybe 30 minutes of a lecture on the differences between Medicare, Medicaid, and nothing really stuck. So I knew if I was going to work in this system, I really wanted to understand it. And I'm also someone, I'm also very, I'm a fighter. So I know one day later on in my career, I do want to advocate. I guess I just don't know what that is. But honestly, after hearing Zachary speak, I'm gonna follow him wherever he goes. Natalia, you want to go next?
Sure. Yeah, I feel like I there's like this vague feeling everyone has that like our healthcare system is not right, and like obviously you see people going without care when they need it. But like I personally couldn't have told you like what exactly was wrong or what we should even be like striving toward. So this internship was a way to kind of like wrap my mind around that and talk about it with other people so that when I come out and as I like go into my career and have positions of influence or the opportunity to, I feel like educated enough to like take on those responsibilities and help like teach other people what the world could look like and like what really is wrong with it right now. So that's mine. Should I bop it, Therese?
Yeah, for me, I volunteered at a homeless shelter for a couple of years. Well, I guess it was more like a community service center, I guess, and I taught ESL to people that experienced or were experiencing homelessness. So, I kind of saw how like a lot of like issues stem from systemic um like issues that were going on, and I realized I wanted to work more upstream as a physician and like move outside of that like patient physician role or like that like sphere. So I worked a little bit on policy before in terms of advocating for poverty bills like the child tax credit and like for like TB. Um, And since I was going to medical school anyway, I wanted to get involved with policy and single payer. Hop it over to Kenzie.
So, growing up, I was always kind of advised not to go into medicine because of the system and how hard it was to be able to treat your patients the way that you knew was best due to insurance systems and stuff like that. So, when I eventually did decide I wanted to go into medicine, I kind of did so with myself on the contingency that I was going to try and understand it and improve it, the system. And I tried to do some research of my own and try and understand it and read, and I found it very confusing and overwhelming. So when I heard about this internship, I was very interested in trying to get like a comprehensive overview of the entire system so that I can better understand what even needs to change because you got to understand what's there first. But I will pass it over to Lauren.
Yeah, my answer is really similar to Natalia's. I also knew I there was something wrong with the healthcare system, but there was a lot that I didn't know about it. And I think we've all like come to realize like we're probably not going to learn about it during medical school, so we have to find it through other resources. And in previous experience before going to med school, I guess I worked at a safety net hospital. I'm not sure if it's a community hospital. And I also worked at it was a nonprofit, but in a, like an affluent area. So the patients that I worked with and even the staff I worked with were so different between the two places. And I just felt a lot more fulfilled in the safety net hospital, and the physicians there also just really enjoyed the work they were doing. So they really encouraged me to continue on that path. And so this is kind of my way of becoming more informed about the patients I'm going to serve and the ways the system is not serving them. Um, and yeah, eventually move towards advocacy in a big picture. I'll pass it to Trinity.
So for me, before starting med school, I was an MA in a pretty small private practice for about like a year and a half, 2 years. And because it was a small practice, I dealt with a lot of the like administrative stuff, even though it was an MA. So I dealt with being on hold with insurance for like hours every day for no reason and like being bounced back and forth. And we had a lot of lower income patients. The practice was kind of set up in an interesting geographical space where we had a lot of patients that were kind of well off and then a good chunk that were from parts of like Oakland and California that didn't have a lot of resources and like didn't speak English and a lot of that. And so not even understanding the system myself and then trying to help other people navigate it was a whole challenge in itself. And I like recognized that there were problems in the system and I wanted to learn more and I was hoping I would have opportunities to learn more and learn how to be an advocate in medical school. Kind of like how other people mentioned, I realized that I would not be learning very much about it in school. So this kind of felt like a good way to learn more and find how I can continue to like learn and serve the community I want to. And I guess I will popcorn to Caitlin.
Yeah, similar to what other people said, I've just have like like a negative view of kind of the healthcare system in America, especially when you just hear constantly stories of people can't afford their life-saving medication because they're jacking up the price, but it only costs like a few dollars to make. And it's kind of, just what could the justification for that be? And then you hear stories of people who are injured running away from the ambulance because they don't want to pay for it. And yeah, so it's just hearing those things like throughout the years, and then just the whole system is so confusing. And then in the past, I volunteered in uh kind of like community soup kitchen for the homeless population in Jersey. And I kind of, through talking to people, you really hear a lot of people became homeless because of health insurance reasons or just unexpected health problems, which just shouldn't happen. So that on top of I also have experience volunteering for a crisis counseling text service, and there'd be a lot of people coming in talking about, self-harm and suicidal ideation. And when you kind of talk to them, a lot of people also mention, obviously, there's a lot of different things, mental health, but a lot of people mention, they're really stressed because of they can't get their medication, it's not covered. So it just affects people in so many ways. And I knew that I wanted to do something to change the system, especially wanting to use kind of like my future platform as a physician, because you're kind of uniquely positioned where you really see what a lot of other people don't see, and you do kind of have that respect that comes along with the position. So I feel like I like owe it to the population that I'm treating to use my platform to advocate for this change, because not everyone has this position. But at the end of the day, I knew I wanted to do that, but kind of I was always unsure of what the actionable steps are. Like I just didn't really know how to get to my goal. So that's why I feel like this internship kind of drew me in and hopefully will kind of give me the steps. And so I have a clearer vision of how to complete that goal.
So I know Jay's
Yeah,
yet
I'll
to
talk more
share,
in
but
Jay.
I'll just not to take away from your limelight, Jay, but I will say that, you know, what all of you shared here, it's really inspiring because one of the things is you're already thinking 10 steps ahead. Many of you have had experiences beforehand in healthcare spaces or health adjacent spaces and notice some of the systemic problems in out there and are already thinking about, how do I do something about it, right? So that's wonderful to see. Um, just very quickly, for me, when I was going to go to medical school, I had worked at a pediatrician's office briefly, and he had two offices. One was in a well-to-do sort of middle-class suburb, if you will, and incidentally in Jersey. And the other one was in more of an inner city area. And so he would see both sort of groups of people, if you will, and you immediately see the differences in everything that they have to deal with. And you, as a physician, has to think about your patient care very differently when a payer is involved and social determinants are involved. So that was something that I reflected on. In medical school, I was involved in student government, and that was sort of my first opportunity to try to address some systemic issues that were affecting us as a student population. So I went to a Caribbean school, and so one of our bigger issues was getting warnings before hurricanes, and we weren't getting good enough warnings. So that was my big issue to try to deal with. And it teaches you a little bit about, when you have to deal with a system, how do you try to shift their thinking? And then in residency, my residency was in central Pennsylvania, and I started in 2016. So this was during the Clinton and Trump won campaign. And so central Pennsylvania is interesting because you can drive from my VA rotation to my inpatient rotation, the 30-minute drive, you'd see like Trump signs go from that height to that height, and then the Clinton signs go up that height and vice versa. So you kind of learn how to deal with people with different sort of political leaning, but they're all your patients and are generally in a very similar geography. Teaches you a little bit about rural health issues as well. And then in fellowship, being in Baltimore, a ton of patients with, gun violence related issues, but also being a sort of clinical hub, you would get patients from all across the region that were very well to do, but they didn't have specialists for certain issues that they were dealing with. So during those residency and fellowship years, I sort of accidentally got involved in the political action committee for our medical society in Pennsylvania. So that was my first exposure to sort of going and having a sort of a dual dialogue with your state legislator. Partly you tell them about policies, but as a PAC, you've also got to give them political contributions. So it kind of teaches you how to speak both sort of languages. And then in Maryland, during the pandemic, we were pushing for telehealth legislation. And so I testified before the state legislature a couple of times. Again, nobody else was doing it, and I was sort of too naive to know any better. So I kind of signed up for it, and it went fine. And we have telehealth law in Maryland. So those were the initial exposures. And then as far as getting involved in federal legislation and policy, I did a fellowship with the Psychiatric Association. They have a congressional fellowship, as do some of the other professional associations. Again, applied on a whim, didn't think I would ever get it, but it was kind of getting tired of clinical work during the pandemic. And so got that opportunity, worked in the Senate for about a year, and mostly on mental health and substance use related policy. But as I was about to leave, we had a school shooting happen in Texas, in Uvalde, Texas. You might have heard of it. It was a couple of years ago. And so we were asked to quickly put together a large package of policies for mental health and school-related services and gun safety. And so they asked me to stay on staff with the Senate for another year or so, and I did that. We passed that bill, and it was a pretty big step forward in that space. And then subsequent to that, I was also asked to work on hepatitis C, which is not at all anything that I'd ever trained in, but it was like a public health problem. Let's see how we could solve it. So that was a couple of years of additional work there. And so during that time, I became familiar with the community health center space and realized that, with the reach of about 33 million patients now, which is a tenth of our population, and the vast majority of them being under the poverty level or on Medicaid or uninsured, that the impact opportunity was huge. So the couple people that I worked with were very nice when I was talking to them as a Hill staffer. And I figured that it would be a good job to have right now when politics is a little bit toxic right now. So it's a better position to be in when you're advocating for others who don't have a lot to work with, versus sort of on the inside where you get to do more, but you're not necessarily always representing the most vulnerable. So that's a quick recap of where I came from and where I've landed. But I do unfortunately have to hop off the call, but I'll leave my contact information here. And if you all have any questions afterwards, please feel free to email or text. And just to say, you guys are an inspiring group of people, and I'm really looking forward to following your careers because I know you all are going to accomplish great things.
Thank you so much, Dr. Jadhav. It has been an absolute pleasure. Well, I will, just so we don't lose this, I'll keep this in our Slack chat, everyone, his information. And yeah, does anyone else have anything else to say before he heads out? No? All right. Well, thank you so much. I hope you have a great day.
You too, and stay cool. It's pretty hot out there.
We'll try. Thank you.
Okay.